Good evening and welcome to UNC Charlotte. We're so proud of our Center City campus and so pleased that you are all here to join us tonight. I'm Nancy Faye Jensen. I'm Dean of the College of Health and Human Services at the university, and it is my extreme pleasure to welcome you to the Charlotte Observer and PNC Bank Community Forum, Solving It Together, Mental Health and Crisis Care. As North Carolina's urban research university, UNC Charlotte is committed and positioned to engage with our local and regional communities across a range of critical societal issues, not the least of which is health. Research, training of our future health and human services workforce, and outreach in the mental health arena is of supreme importance to us. This Thursday, the 21st, here's my shameless plug, here at the Center City campus, a special art exhibit, The Art of Recovery, will occur. This has been organized by our college's Department of Social Work. The Chair of Social Work is here, and many of our faculty, in collaboration with UNC Center for Excellence in Community Mental Health Association of Central Carolinas, Person-Centered Partnerships Bridges program, and Ocasio Incorporated. This art exhibit seeks to reduce stigma that's related to mental illness. Please visit our website, the university's website, to gather more information about this wonderful free event, and I hope to see you there Thursday. Throughout this evening's discussion, we will undoubtedly hear that the time has come for our nation to develop new, completely new approaches to mental health services. One tremendous opportunity area for new approaches is actually housed at the University of North Carolina at Charlotte in our Big Data and Informatics Initiative. Health informatics is a field rich with promise and the ability to, with improved fidelity, position health and human service agencies to be as effective as possible in responding to those with mental health issues, as well as their families. And today, our college actually enjoyed a visit from one of your panel presenters today, the new Mecklenburg director, Phil Endress. Our faculty were the grateful recipients of his perspective and confirmation of the direction for and needed investment in integrated mental health services. We at UNC Charlotte look forward to being active partners with Phil and with Mecklenburg. But now, it's my pleasure to introduce Weston Andrus, the Regional President of PNC Bank, covering Charlotte and the Western Carolina market. Weston, a longtime Charlottean, assumed his role with PNC just this past fall. He and PNC have made Charlotte one of the bank's highest priority markets, and we are all so appreciative of how they have already stepped up to make this evening's important forum possible. So please join me in thanking and welcoming Weston Andrus.
Thank you, Nancy. Good evening. I'm delighted to welcome you to the second in a series of forums organized by the Charlotte Observer and PNC Bank to explore issues important to our community. So thank you for being here tonight. It's citizens like you who make a difference. I also want to thank UNC Charlotte for holding the forum in the state-of-the-art facility, and I want to welcome our distinguished panelists. PNC is celebrating our first anniversary in the Charlotte community, and our year has been exceptional, both in terms of our acceptance and our growth here, as well as our philanthropic work. While our major philanthropic work is focused on one of today's primary challenges, early childhood education, we realize the need for our communities to identify challenges and tackle issues in a collaborative way. That's why we've joined the Charlotte Observer to present more forums in 2013, each examining issues that confront our citizens and communities. Tonight's forum is especially important as we grapple with the important issue of mental health services and how best to support the people in need. So once again, we appreciate your participation. We hope you can stay after the program and enjoy some refreshments. Now, for more on tonight's program and how it will work, please join me in welcoming Charlotte Observer editor Rick Timms.
Thank you, Weston, and good evening, everyone. And I want to offer our sincere thanks to PNC for actively supporting tonight's forum. Also, Dean Faye Jensen, we are grateful to UNC Charlotte and to the College of Health and Human Services for hosting us tonight. You know, the university opened this campus less than 2 years ago for the express purpose of collaborating with the community. And tonight is just one more example of that. As you can see, that UNC Charlotte is committed to doing this. As Weston noted, this is the second in a series of issue forums that we are calling simply Solving It Together. At the Observer, we believe that there is more to news than just describing the problems. Solutions that will help us solve our problems are news too. They're big news, in fact. And there's no better way to identify possible solutions than to have a conversation in a room full of people who care and people who want to help. And that's what we have here tonight. Doctors, patients, police officers, parents, scholars, sisters and brothers, our elected officials, thank you all for taking the time to talk about better care for our mentally ill, especially in times of crisis. We also thank more than 20 special guests that we have with us tonight who are listed in your program as panelists and resource specialists. You will hear more about them later. Many will also be available later in the lobby at the reception, and we hope you will stay and take advantage of this opportunity to speak with them. Finally, a special thank you to two people who provided key advice as we planned for this forum. Ellis Fields with the Mental Health Association of Central Carolinas and Melissa Mashburn with MECLink. And now I would like to introduce tonight's moderator, Observer editorial page editor Taylor Batten. Taylor is an award-winning journalist with more than 20 years of experience covering major issues in local and state government. He joined the Observer in 1995 after writing for the Associated Press. He has also written for the New York Times, the Boston Globe, the Dallas Morning News, and the Miami News. Taylor became the Observer's editorial page editor in 2008, and since then, the North Carolina Press Association has named the Observer's editorial pages as the best in the state, and in 2010, it named Taylor Batten as the state's top editorial writer. Taylor has poured over dozens of questions that many of you have sent in, and he is prepared now to help our panel provide as many answers as possible. So please join me now in welcoming Taylor Batten.
Thanks, Rick, and thank you to all of you all for being here tonight. Thank you for braving the rain and the cold weather. I thought that with this past weekend that we had turned a corner with the weather, but I guess we're gonna have to wait another week or two before we fully spring into spring. So I do appreciate you all coming out. As Weston and Rick both said, this is the second community forum that the Observer has hosted with PNC. The first one was on congressional gridlock, and as we were talking about what the topic should be for our second forum, mental health care really leapt to the top of the list. It's always been a big issue, but now it has become on the radar of people nationwide. And it's just such a deeply important topic in our community, and you know, it has some problems that need to be talked about and worked out. So it's gratifying to see all of you all who care so deeply about it. And I'm looking forward to having starting a conversation that maybe will be a beginning of doing so in a lot more public fashion. I'm hopeful that tonight will really advance the discussion in meaningful ways and possibly lead to some movement and some solutions. And I think there's a good chance that we're gonna have a very fruitful conversation tonight because of so many people are here from so many different components of the mental health care system. All of you all, our panelists, some of our special guests here in the front, and all of you in the audience, each of you bring different perspectives from different pieces of the issue. And I think that's really going to help us have an informed discussion tonight. A few logistics to go over. We do want to answer as many questions from you all as possible tonight. That's the whole idea. You all submitted more than 200 questions when you registered for this event, and we went through all 200 plus of those. Lots of really good questions, and so we want to get to as many of those as we can. You can also give us more questions if new questions come to mind during the conversation. You should have note cards. Did you all get note cards as you came in? And if you don't already have a note card, Jen Rothacker and Tracy Curtis in the back will be handing those out. You can write your question on the note card. Please include your name, pass it to the end of the aisle, and Jen and Tracy will pick those up, bring them down, and our folks will go through those, and we'll try to have as many of those questions answered by our panelists and special guests as well. Some of you may have questions that are very specific to your case or the case of a family member, and we ask you to save those if you can until after the panel discussion. There's going to be continued conversation after we're in here. There's a reception following the event. Different organizations, as you probably saw, have set up outside, and so we'll be able to have more one-on-one conversations after the panel discussion. There's also, as I think Rick said, a list of resources on the back of your program. I encourage you to look at those and learn more. You can contact those organizations to learn more about what they do. So I'll introduce our panel in a moment. We also have a number of local experts here tonight sitting down front, representing a number of different organizations: Charlotte Mecklenburg Schools, Mecklenburg County, MecLink, the VA, the National Alliance on Mental Illness, the Mental Health Association, and a number of other organizations. So thank you all for being here as well. Okay, I'd like to introduce the panel, and then we're going to watch a short video that puts the topic into some context. I'll start with to my immediate left. Dr. Roger Ray is Executive Vice President and Chief Medical Officer for Carolina's healthcare system, which operates CMC Randolph, the county's only psychiatric hospital. I'm not going to read you, all these bios are in your program, so I'm not going to read these to you, but just give you the highlights. To his left is Pat Cotham. Pat is the chairman of the Mecklenburg County Commission, serving her first term, and the county is responsible for funding many of the county's health needs. To her left is Phil Indris, who became director of MecLink this fall. MecLink is the managed care organization that is now administering behavioral health care in Mecklenburg County. To his left, Chief Rodney Monroe has been the chief of the Charlotte-Mecklenburg Police Department since 2008. And to his left is Mebane Rash. Mebane is an attorney with the NC Center for Public Policy Research and editor of its journal, North Carolina Insight, and has done a tremendous amount of research and writing about mental health care in North Carolina. Thank you all for being here.
Thank you.
Okay, so we have a video, I believe, that puts the topic into context. I believe we have a video.
Hi, I'm Michael Gordon with the Charlotte Observer. Our topic is mental health. Our question is this: what grade would you give emergency care services in Charlotte-Mecklenburg? What follows are the opinions of 5 people who are invested in the answer. They are a judge, a doctor, a mother, a father, and a client. Here's what they have to say.
I would give the physicians an absolute A. I would give the staffing a D as far as having psychiatrists, psychologists. They don't have them on staff when you go into the emergency care. My daughter had a treatment done. She went in on a weekend, tried to attempt to commit suicide. They had no staffing. She was admitted, had to spend the entire weekend in the hospital in a bed because they had no treatment, no one to be able to come in and make an assessment, an evaluation. And it wasn't until Monday at 3:30 for the psychiatrist who is on duty to come in. Healthcare system, they do not have a treatment facility for adolescents in Charlotte. They have Carolina's Behavioral Center, but it's really not geared towards residential treatment, and they had no beds available. So my daughter had to spend the entire 5 days at CMC until I was able to find a residential treatment facility. Thank heavens that I have an absolutely fantastic psychiatrist, Dr. Lelio, who is in charge of CMC's psychiatric care for them, and he's probably saved my daughter's life.
I think it's actually 2 grades. The first grade would be to emergency services available in the community the way they are now, and I'd say somewhere between a B and a B minus. I think the physicians and the staff of emergency rooms are trained not necessarily to deal with psychiatric issues, but they do the best that they can with the training that they've got. Now, the second grade, where things begin to fail, is disposition of the patients in appropriate environments. Where do we send this patient to? How do we best provide for care? What's available as an outpatient? What's available as an inpatient? And I think that takes a collaboration between the private hospitals, private psychiatrists, and the community sector to be able to get these people taken care of and do the best that they can when given an opportunity to be treated adequately.
I would assign a grade of a solid C, maybe C plus, to our mental health care system. And the reason for that is though we have a very good quality of care and high quality care providers, where our system is lacking and falls short is in the accessibility of that care. It's very difficult for consumers to access what they need, and also the affordability of the care, and that our care is not always available from a financial standpoint to those individuals who need it, regardless of their insurance status or socioeconomic status.
How would I grade and explain? F in the past, current fair D. In 2006, North Carolina's mental health system received a grade of D. Years later, the grade has remained the same, but does not even begin to convey the chaos that now pervades the state's mental health care system. Good news. We now have a mobile crisis team and some CIT-trained law enforcement. But this needs to be funded more, enhanced, and highly advertised to educate the public at large. Who really knows about MCT, CIT, and NAMI here in Charlotte, Mecklenburg, National Alliance for Mental Illness? Our son Vincent took his life in 2006. Suicide.
I've slept on park benches, in cardboard boxes, sleeping bags and tents on the sidewalk, and in the forest, just to find somewhere to lay my head. Through this program in urban ministry, they helped me to get off the streets. June 2012. I've been in housing since then, here at Moore Place. I've been struggling with mental health issues. I would give the mental health community here in Charlotte a grade A for an outstanding effort in helping the mental health patients here in Charlotte, because they show a lot of concern and they're eager to assist the mental health patients here with medication, therapy, and counseling.
One thing I forgot to mention, you also can submit questions using Twitter and use the hashtag #SolveTogether, #SolveTogether, one word, and we'll be monitoring that that's just another way to submit questions. So speaking of solve together, we want this evening to be solutions oriented, but before we can dive into solutions, we need to kind of get a handle on what the problem is and the scope and the breadth of that problem. So as you all of you know better than anyone, there's a stigma around mental illness that gets in the way of addressing it properly. And I hope tonight can be one small step in starting to address that and eventually eliminate it. Many of you in the audience asked about this when you registered, and so I wanted to start there. So the question for the panel is, how do you all see stigma being a barrier to mental health treatment, and how can we eliminate it? And one audience member specifically wanted to know what your organizations are doing to dispel myths around mental illness and to educate the public. So any of you all can jump in. Dr. Ray, maybe you can start us with that, and what are you all able to do to educate the public on this issue?
Sure, thanks, happy to do that. I want to add my thanks to others for the groups that came together to put this together. Important conversation, important learning for us, I suspect, and we appreciate the opportunity to be here and talk with other leaders and others of you who are interested in the topic. As it relates to stigma, probably important for you to know I'm a neurologist by training, practiced about 15 years prior to becoming an executive physician. The stigma is real. I think that's the first step, is to acknowledge it is a reality for any of us who endeavor to improve behavioral health services, and we need to deal with it up front. As a neurologist, I would tell you that we got a chance to treat many illnesses, paralysis, or other neurologic conditions. But as soon as the condition began to affect behavior, it changed for everyone. Why is that, do you suppose? I suppose, as many have written, that has to do with the fact that we channel so much through behavior and communication about what we think of others. But nonetheless, I think important to know it's a human thing, a human reaction, but in fact, a human thing that we must find a way to rise above, to go beyond. An illness is an illness. It's chemistry, it's medical, and therefore really no different than other medical illnesses, and it's ours to understand that when it affects behavior, we have the capacity to teach ourselves to rise above that and look beyond it to work with the individual better. What are we at CHS doing? We're doing a number of things. We have a whole set of initiatives around patient-centeredness, trying to change over time our construct of healthcare from being about a facility or a practice or a physician or a team, and be more about the patient and the whole patient. And therefore, the patient's behavior and any stigma that might be attached to the patient becomes our problem, not the patient's problem. That's the first thing. Second thing is we're engaging with many communities, a number of you probably in the room, because education, discussion is really the center point of helping us all and each elevate our game so as to be able to rise above stigma and deal with patients where they're coming from as they deserve so much.
Ms. Rash, how about you? You've written a lot about it, and you also have personal ties to it. When
Sure.
you hear talk about stigma, what stood out to you?
So I am with the North Carolina Center for Public Policy Research, and we have been studying mental health reform in North Carolina for 5 years. And the first thing that we do when we talk about stigma of mental illness, developmental disabilities, or substance abuse in North Carolina as we try to define the scope of the problem. So the state estimates that there are 1.37 million people across the state that have either mental illness, a developmental disability, or substance abuse. That's 14% of our state population. 300,000 of those are children. And the reason it's important to talk about the scope is because it helps people realize that this issue touches all of our lives. Rich and poor, all races, all ages, urban and rural, Democrats and Republicans. And the next thing we try to do is talk to people about the need to tell stories around this. And it's hard. I appreciate you being here tonight. It's hard for people to come and tell their stories, but it's also really important. This issue is personal and professional for me. I started in this work 2 decades ago as working for Carolina Legal Assistance, which was a mental disability law project. But it's also personal. I have an uncle who has autism and developmental disabilities. He's lived in a group home in Roxborough almost all of his life. But I also have a son that struggles with anxiety and depression and is in mental health treatment. So the reason it's important for you all to tell your stories is because you are the public in public policy. And if I go to the General Assembly and I testify about the numbers and how long the waits are in the ERs across the state and how long people are waiting for a bed, that's important. But it is another thing to walk into that building and tell the story of a 12-year-old girl who waited for 6.5 days in a hospital emergency room for treatment. Her mother was 90 miles away. She didn't have a bathroom in her room. She was on a gurney for 6.5 days. There was no exercise. There was no schoolwork. And so from boredom, she begins to self-mutilate. And she doesn't get a bed until she herself picks up the phone and calls 911 and says, "I need a ride to Butner." And those stories help policymakers understand this issue in a very different way than just looking at the numbers. And it helps them understand that the public and public policy is something they've got to pay attention to. These are people that are constituents in their districts. So that's what we are trying to help people do to work on the stigma across the state in addressing this issue.
Chief Monroe, is there any role for the police department?
Well, I heard the doctor speak earlier about it being about the patient, and I think that couldn't be more so of the truth. Unfortunately, we deal with a lot of situations that it is about the person, it's about the patient. And for any other medical problem that a citizen may endure, you pick up the phone, you dial 911, either an ambulance will come and take that person to the hospital depending on their injury or illness, or you can take that person to the emergency room or to a doctor. But a lot of the cases that we see and we respond to, there's a struggle in navigating that system when it comes to mental health issues. And I agree that we don't talk about it enough. And I think that's part of the problem, is that it's behind a shield, and it's hard to penetrate that shield, and it's hard to come from behind that shield so that more people can understand. And I believe that the more people that can understand the issue, the more and greater your opportunities are to help address that particular issue. So for us, it's a lot about the secrecy, the mystique about mental illness that challenges our officers each and every day.
Well, and along those lines, we heard a lot from you all saying that there's not enough collaboration among all the different agencies and people who are involved in delivering care. One member of the audience asked this: what ideas or plans do you have for ensuring that all of the entities involved in a particular client's life and care are able to share information quickly and effectively so as to streamline assessment and appropriate interventions? We also heard a lot of stories about clients getting passed around from one caseworker to the next, and another audience member asked, is there a mental health clearinghouse in Mecklenburg County? I think I know the answer to that, but Mr. Endress, maybe you can talk a little bit about that, because you're going to be having to organize a lot of, I would think, collaboration, and will MechLink be a type of clearinghouse?
Thank you, and I'd like to thank everybody for coming here tonight as well. I think this is a wonderful opportunity to not only address the issue of stigma, but also to really talk about, you know, the services that are available in this community. MechLink began operation 18 days ago. We are the MCO for Medicaid managed behavioral health care in Mecklenburg County. And as such, and as part of our operation, we operate a 24/7 help desk, helpline for people to call to be able to access services in a timely manner. So I guess that's sort of a clearinghouse functionality, but we go much beyond that. We talk to the person and or the family member who's calling and try to understand what the issues are that they are dealing with, so that we can make an appropriate referral to a service provider. One of the issues, going back to the previous question about stigma, is that it keeps, and Chief Monroe was right on when he said that it's very secretive and people hide and try to cover that up. And through forums like this, if we can talk about the issues and, you know, whether it's an embarrassment or not to us as an individual, it's something that we can deal with early, so that we're not having to involve the police or other emergency workers in a crisis situation. We want to be able to identify individuals that are beginning to have a problem, so that we can identify resources to deal with that effectively. There are strategies, there are treatment strategies available through clinics, through providers, through a network of providers that we have in the county that can effectively assist and support somebody to deal with the issues of mental health and or substance abuse issues, so that it doesn't get to a point that we're involving law enforcement or the fire department in taking somebody to an emergency room, and that being the only source or the first source of treatment services. The more that we can identify the issues up front and be open and honest about them, the more that we can divert people from that level of treatment and reduce the burden on law enforcement and the emergency departments. So I think that the issue of stigma is the number one issue that we confront every day, and it has its impact on how all other services are delivered within the community.
Excuse me, Taylor. I think that's important. And when I speak about the secrecy and the stigma associated with that, we also bear a large portion of that secrecy ourselves, excuse me, within the various organizations that we represent, whereby even the sharing of information ourselves amongst one another that can help a person as a whole versus just dealing with different pieces of that mental health issue, whether it's just when you call the police or when someone is visiting an emergency room. I think that the coordination, and I was talking earlier about there's systems out there that allow organizations to share information. Sometimes I think we hide behind the privacy issue to the point where we become either resistant or numb to being able to respond to certain things. So that's part of the secrecy that I was speaking about also.
That's interesting, because I heard a lot of that kind of thing, and that a lot of you were frustrated from how hard it was to share that information, and you know, even to get, there'd be somebody who qualifies for Medicaid, but you know, they might get turned away from an initial assessment because, you don't know if they qualify for Medicaid, and there's no easy database or, getting that paperwork shared, or that's just one example, but seemed to be something that could be done better. Commissioner Cotham, the Board of County Commissioners ultimately oversees MecLink. Have you, what are you hearing and what are you learning along these lines about the need to smooth some of the communication and collaboration among the different players?
Well, I think we've only been open for a few weeks at MecLink, and I know we'll have a great first month, and I know it'll be a great asset to the community. So I think it's a little too early to do an evaluation of that, but I can say that not only am I the new chair of the county commission, but mental health is something that was a reason why I ran for office. So I'm also, as I wear the hat of the county commissioner, I also wore the hat of working at a nonprofit where I helped people who had a criminal background, many of whom, I'd say 40 to 50% of them had mental health problems. So as I listen to the conversations, I think about, just as Mr. Melville thinks about his dear son Vincent, I think about Bruce, I think about Demetria, I think about Ron, I think about people that I spoke with and how they also had the stigma. And I also think about the whispers of another woman saying, my son is having problems. But nobody knows what I'm telling you. I'm sure you've all, had that as well, or my cousin, or my husband, or whatever, my mother. I think about that too. The stigma thing is something that we as a community and as a nation need to address. But mental health hits every different economic group. It's not just, poor people, it's not just men, it's not just women, it's children, it's adults. So we really need to come together. And I worked at the Center for Community Transitions for 3 years, and I would still be working there part-time, but they lost some funding, so I lost my job a few weeks ago. But I hope that they'll get some funding back. But Washington, I was on a federal grant, and I helped people find jobs. But I can tell you, I remember, the phone call from Bruce, who called me, Miss Pat, I was going to kill myself, but I called you. It makes you never want to not take a phone call. The stigma, he was embarrassed, and a lot of the people are embarrassed, and they don't, when you talk about, as soon as you say Billingsley Road, they just go, oh, I don't want to go there. But they need to, but there's that stigma, even among people, poor people. And I would really like it if I learned that in working with people with a criminal record, many of whom had mental health problems, they don't have coping skills. They don't know how to cope. So if you have a problem, whether it's, you don't have transportation someplace, you know how to think it through. Like, well, what am I going to do? I need to call a friend to try to help me. They don't know how to do that. They don't know how to do that. They're either going to go hit somebody or they're going to take drugs. They don't know. They don't have a lot of choices, and they don't know how to think things through. But they also need to feel safe. Like where I worked, they felt safe. They would come in, and they felt safe because nobody was judging them. And I've often thought when I was working there that it would be a good idea if there was a mental health assessor or someone to evaluate somebody at a nonprofit where there's office space and where they feel safe, and they're more likely to go and talk and get the help, because they don't, like the chief of police said, they don't know how to navigate the system. They don't know how to do it, and so they don't do it. But if they were at a safe place, they could be more likely to do that. And so I just often thought, but this was one of the reasons why I ran for office. And I see two of my commissioner colleagues over there, Commissioner Leake and Commissioner Fuller, and on the campaign trail, we talked a lot about mental health because the citizens talk to us about it. And so this is something that is a big reason why I'm here, why I ran for office. And so I think it's something that we have to address as a community, and we have to listen to people. We have to listen to the whispers of the families that are struggling, and we have to listen to the people, and know that a lot of them are not getting the help because they don't know how to do it and they don't feel safe. And if we can make them feel a little safer, I don't know if that makes sense to you, because I'm not an expert here. I'm not an expert, but maybe the experts can think about that. But I just think the nonprofits, we're working with the same population. And so that's just something I would like people to think about.
Dr. Ray. We're going to,
Okay.
for the panelists, we're going to start sharing a handheld mic because your lapel mics are coming and going a little bit.
Just a couple comments.
Is that working? Can you all hear this mic?
Can you hear me?
Say something brilliant. We'll tell you if we can hear it.
I didn't have anything brilliant planned. I'm sorry. I think we have to own a little of that. As I hear the conversation, as I walked in this evening, I got a chance to meet one of you who shared with me a story about a family member or an acquaintance who had recently been with us at CMC Randolph, and to paraphrase, said, when we needed it, you gave us safety. When we needed it, you gave us hope and support. And it is a wonderful story now, a time later, looking back on it. We probably own that of the many stories we tell, we don't tell those stories so often or so effectively so as to help pull patients toward the help that is sometimes there waiting on them and help it get past the whisper stage. The other question you asked about was collaboration. I just quickly on that, I do think we are at a moment where there is more possible maybe than at sometimes in the past. With the emergence of Mechlink and Community Care of North Carolina, as many of you know, is a statewide organization that is provider-sponsored largely, but not entirely, who works statewide on policy and Medicaid issues and also performs care coordination and lots of very needed services. They have a new collaboration of sorts with Mechlink, and I think can really help move us ahead as it relates to coordinating the care in that patient-centered way. I'll just give you one data point. I was meeting with CCNC in the last couple of days. Most of us in the room would say, if I went to the emergency room this year, that would be a huge event for me, and hopefully I only went once. If you look at patients who last year went to the emergency room more than 20 times, imagine that, more than 20 times, and there are many of them, 80% chance that those patients will have a significant mental health issue that is largely going unaddressed. So if we're ever going to rein in healthcare spending overall, if we're ever going to motivate health overall, we've got to seize the moment. And I do think that Mechlink, CCNC, the providers in the communities maybe have an opportunity for some collaboration that are better than we have seen in the past.
I want to remind you all that you can fill out those note cards with questions and include your names and pass them down to the end of the row, and we will look at those. And Rick has.
Are we on here? Yeah, okay, good. Would the person who's a public defender who submitted a question raise their hand? Okay, we're going to go right up here. If you could work your way down the aisle here and ask your question. We were particularly interested in the second question that you had posed here.
My name is Stephanie Edelman, and I'm a public defender. And I had two questions. The second one is I think most of us in here know that the jail has basically become a large mental health hospital. And I was hoping that the panel could address how we as a community could address that, how we could stop treating the mentally ill as criminals and start treating them with the dignity and respect and really what they deserve.
Thank you. Chief Monroe, you want to take first crack at that?
Well, I mean, I think that's a great question, and we in law enforcement struggle with that because there's a fine line sometimes when it comes to activity and behavior, whether or not it falls along the criminal lines or some other form. And what we've done over the years is we've begun training our officers, both our patrol officers as well as our school resource officers, to help them to be better able to recognize mental illness in a sense and how it manifests itself into something else that we see out on the street. And being able to use different skill sets to try to de-escalate some of those situations and hopefully be able to make the proper referrals or have the proper support systems immediately available in order to help address crisis situations. Because a lot of times I think it's easy to say that I recognize that there is a problem here with an individual, but if you stop and think, what are the choices, what are the opportunities at 2:30 in the morning in order to address that particular issue in that individual? The resources are limited, and with that, the choices become limited. Ultimately, you want to err on the side of protecting that individual and the public. So a combination of increased opportunities of resources available 24 hours a day to address the real issue so that jail doesn't become the automatic option, and better training and more training of officers, not only patrol officers. I know that Chip Bailey, there's close to 300 officers within the jail system that has been trained in crisis intervention. We're approaching about 300 officers ourselves. We just applied for another grant to hopefully train another 500 officers over the next 3 or 4 years. But again, that training is only one option. And if there's not other options in which an officer has the ability to redirect or divert an individual into immediately, then I think that we're going to still struggle with the issue about jail being an option. Because when you look at the activity, it could go either way. We're trying to lean more towards that option being some other resource, family, mental health providers, even being able to readily be able to reach out to a doctor to help assess a situation at 2 or 3 o'clock in the morning, whereby we can redivert that person versus taking that person into custody.
Judge Bell, I don't want to put you on the spot, but with this question, I would be really interested to hear your perspective on the role of the justice system in all this. Lisa Bell, Judge Lisa Bell is the Chief District Court Judge for Mecklenburg County. Judge, would you be willing to speak to this?
Thank you. I appreciate the question, and one of the scenarios that came to my mind actually as the question was being asked and as the chief was responding was a situation that I think highlights the way that we could as a community address the issue and decriminalize mental illness. It was a scenario that came up several weeks ago where a young man had taken a cab from Tennessee to the Charlotte Douglas Airport. And
can everyone hear Judge Bell?
You hear me?
Just hold it pretty close to you.
Okay, the young man had taken a cab from Tennessee to the Charlotte Douglas Airport. He engaged in some behavior that was unquestionably criminal, but he also exhibited behavior that was indicative of a pretty significant mental health issue.
Chief Monroe's officer recognized that, and rather than taking this young man to jail, took him to the behavioral health center, where he was admitted through the emergency department, and his treating psychiatrist recognized the need for a longer-term treatment program for him. This was a scenario where the family had the benefit of private health insurance and was able to travel here and arrange long-term care for this young man, and also arrange for legal representation. But the attorney came to me because there was a warrant outstanding, and this young man was going to go to jail if he was released from the behavioral health center. And it just took communication with the sheriff's office and the police department and the behavioral health center and the district attorney's office and the court in just communicating with each other and to allow this young man to actually be placed in a residential facility as opposed to going to jail. And everyone was on board with that. But that key initial decision point was with that officer who made the decision based on his training and his personal experience to take this individual to the hospital and not to jail. We are working now as a collaborative effort through the Criminal Justice Advisory Group, and the county has been working for a number of months now through funding called the Justice Reinvestment Act, and it is an effort to redirect monies to spend them rather than on the back end of crime, on hopefully the front end of crime, which is the preventative measures. One of the things we're looking at is more of a crisis center where individuals can be taken by law enforcement that gives them that opportunity to be assessed and have that intervention in some way that is not incarceration. The police department, CMPD, has been a part of this, the sheriff's office, the county, the court systems, and that would be ideal because when there's no place else to take these people, sometimes, as Chief Monroe said, it's a choice between something bad and something worse. It's jail or leaving them on the street where either they could injure themselves or cause harm to another person.
So that would be a new entity, a new
A
center.
new entity. In fact, we had a presentation several months ago from Bexar County, Texas, I believe. They've got such a crisis response facility where individuals can go. It's open 24/7. Law enforcement can take them there. It accesses various mental health services as well as other services that a person may not need mental health, maybe substance abuse. It may be simply a housing issue that they have nowhere to go, that it's a residential issue. But this facility, it's kind of that clearinghouse physically where those decisions can be made, and the accessibility to those services can be facilitated by professionals.
Is that a county-funded thing?
It would be partly county funded, but it was partly federal funding, I believe, that's available, and private funding. And it might be that Michelle Lancaster could speak to the funding issues around it. But from the court perspective, it absolutely is needed. Because once these individuals get into court, and it's what I spoke to on the video about the accessibility and affordability, you recognize there's a need, but there is no way to get these individuals who don't need to be in jail, who may not need to be on probation and may not be successful. What they need is mental health treatment. But when they are transient, when it's difficult staying in communication, they need someone there holding their hand, metaphorically, to help them access and navigate the system. Do you want me to
Thank you.
ever speak to funding?
Would you like to?
Great job.
Okay. Thank you, Judge Bell. Okay, quick from Commissioner Cotham, and then I think Rick has another question from the audience.
I just wanted to add about, in my work with people who've been in prison, I would really like to see a better coordination with the state prison system, or now I think it's called Department of Public Safety. So I would often have people who just got out of prison, and then I'd be talking to them, and I could tell there was an issue, and I would say, did you get any medication when you left 2 days ago or yesterday? And sometimes they'd say, yeah, I got this bag here with these pills in it. And then they say, well, can you get me a job? Then he would just change the subjects. But they don't seem to have coordination with how do you take those pills, or what's the next step? Or I would say, did you connect with anyone here in Mecklenburg? Did they give you anyone to call? No. So that's another problem. Certainly our jail does a much better job with this, but I would like to see more coordination with the prison system. when people are just getting out and they have medication, or they don't, or they need it. Because if they don't get it, they often get themselves in a problem, and often they get rearrested. This man, several of them, I'm thinking of, we were able to get them help, and I was able to find them a job, and then we would stay with them to help them with their medication. But if they hadn't found us, Lord only knows where they would go.
You have another one?
Yes, is Lee Pettigo. Raise your hand. Yes. Lee has a question about MechLink.
I'm curious as to who are going to be answering the phone calls at MechLink, what credentials they have, and how many people are going to be answering the phone calls for the high percentage of the population that hopefully will be calling you. And the second part of my question was something that Officer Monroe spoke to. What systems are you talking about that allow sharing of this information? I don't know what you're talking about.
Which part do you want?
Either part.
I'm going to let.
Oh.
There are systems out there that allow that.
So in some of our work, we've been looking at other states.
Ma'am, hold that closer.
We've been looking at other states, and one of the states we've been looking at is South Carolina. South Carolina has an information technology system in place that allows their departments to share information. So the education system, social services, law enforcement. Well, the example I was giving you was that if somebody was arrested, when they pulled up his record, they could see, is he getting services already? What services is he getting? Who is he? Who are his providers? Is he in the education system? And the General Assembly had someone from South Carolina come up and testify about the system in the fall. And so it is something that our state is looking at, and I think it would go a long ways towards communication and collaboration, and would keep people from having to pick up the phone and make those phone calls themselves.
Mr. Indris, I think you said you're already getting 2,500 calls a week, is that right? And just getting ramped up, so that number is probably going to climb. You're going to must have a lot of people answering the phones.
Yes. We are receiving about 2,500 calls a week at the call center. The staffing is that we have staff in the call center. I believe we have 26 people answering the phones. We have clinical backup, trained clinicians, social workers, nurses, psychologists, licensed professionals in the state of North Carolina to be able to, I don't want to say it's a warm handoff, it's really a hot handoff. There's a connection so that if somebody calls in and is in an acute crisis, the clinical person can come and take over that phone call right from the person who actually answered the telephone immediately. It's not, we'll get back to you, can I have your name and number? There's a real handoff immediately for that individual. We have done approximately, in the 18 days that we've been operating, approximately 8,000 authorizations for services, which I think is quite remarkable. And it's really a system that we're growing into. I'm not going to make any promises that it's going to be absolutely perfect every time. It is something that we're learning about. We talk about it every day. We talk about our calls. We talk about how we handled things. We talked about the authorizations. We talk about alternatives that we could have taken in providing services to individuals. And this is something that we talk about every day in our meetings. And it is a 24/7 operation. During the evening hours, we have an on-call system that is staffed, again, by paraprofessionals and professional staff. And those reports come back to us every morning at, I believe it's 7 o'clock in the morning for the calls that have come in overnight.
I want to go back for a minute to the question of prevention. A couple of you have touched on prevention, and tonight's mostly about emergency care, but obviously the two go hand in hand, and we had a lot of questions from you all about how we could have better early treatment and prevention and avoid the crises and ER visits in the first place. One audience member said, as a professional counselor, I am aware that many have to wait for several months for non-emergency behavioral health appointments, which starts the crisis cycle over again. What can be done to address this? And others pointed out that without that early diagnosis, the treatment and sound case management, you end up spending a lot more money on crisis care.
I'll take a shot at that one. I think that one of the things, mottos that we're learning to operationalize at Mecklink is what we've referred to as the 5 rights. It's the right service to the right individual at the right time for the right outcome and the right cost. And this is something that is absolutely critical, that we need to be able and work with the broader community to be able to identify individuals who might be having a problem so that we can do some outreach to them. We have services that do outreach in the community. Pat has talked about services in the agency that she has worked in that identified individuals who had stressors. We need to be able to talk to those individuals and to have them make that connection to us so that we can then begin to do an outreach with those individuals. Chief Monroe comes in contact, and his officers come in contact with people every day, every shift, that may not have a mental illness that warrants being taken to an emergency department, but they said, we can give you a phone number we can call, we can make a referral for you to be able to access services. And yes, Mecklink is about Medicaid managed care. We also respond to individuals that are medically indigent, that don't have any sort of health insurance, and try to make those connections so that they do not need to go to an emergency department or become involved with the court system and the judicial system to be able to access services. If somebody has health insurance, we will be able to answer their questions, but we will also then help facilitate a linkage back to their healthcare provider to be able to provide more appropriate access to treatment services that they may have in their network. So it's really a growing experience for us, a learning experience for us to be able to manage the services within Mecklenburg County, and hopefully to be able to assure more timely access to appropriate treatment and support services.
I saw Ellis Fields. Ellis Fields is the executive director of the Mental Health Association in Charlotte. And are you surprised that it might take somebody months and months to get a non-emergency appointment assessment? What have you seen along those lines?
Honestly, not surprised, just based from community feedback. We are constantly in touch with our friends at the hospital system, and we know what the issues are. A lot of the barriers to solving those issues come down to funding, and that's coming. We need to work with our state politicians, and that would be my plea to the audience members is my organization is known for advocacy. We're looking at public policy around mental health, primarily public mental health service delivery system. And it takes everyone in this room to educate themselves about the issues, about the barriers, what's needed to solve those problems, and be vocal. I know Pat will love this, but call Pat. Call her fellow commissioners that are in the office, our state legislators. This is particularly important. So surprised? No. I know we're taking steps. We've made some progress. We'll have more beds here eventually when the new facility in Davidson opens. But it's what I hear constantly.
Thank you. Dr. Ray.
Just a comment. Lots of people know about the acute care environment, CMC Randolph, and a coming attraction for a facility that we're working hard on in the Davidson community, but probably maybe not as well known that there is a substantial clinic operation associated with the campus at CMC Randolph. I believe last year we saw about 50,000 visits there. And that capacity is not enough, as you've heard, and lots of stories that would indicate that. I would get you to help us do one thing, and that's expand our thinking a little bit about what screening and early detection might be. For us, that's going to be a move into our primary care environments everywhere we are, and that's hundreds of places through the communities that we're able to serve. Our vision of it is that at some point, being screened for a mental health condition would be as common as answering a question about blood pressure, diet, or any other aspect of health in the primary care setting, where it's way upstream of most of the problems we see and where a lot of the crises are that we are talking about and will keep talking about. So we're trying to expand our horizons from way upstream and early in the condition so as to try to identify who needs help early on. 1 in 4 of us sitting in this room, or on average, will need the help of a mental health professional sometimes during our life. It is not somebody else, it's not a rare thing, and we can do a lot better job by expanding the involvement of the healthcare providers who we have today at being better trained at helping.
Well, that is so essential. We don't wait to have a heart attack to get any kind of treatment or attention. When we have high blood pressure, we start working on it right then. So, Ms. Rash.
So that raises a question, which is the state has made a different choice than other states have, and then the trend is nationally. North Carolina continues to carve out mental health care and have people served separate and apart from their normal health care needs. In most states, we're seeing the states move towards integrated health care. And one of the reasons that you may not have routine, non-emergent care available is because of that decision. So if anybody wants to comment on that, I'd be interested, but that's one of my theories.
And we did invite state legislators to join us tonight, but they're in session tonight, and we're not able to be here. Rick has another question from the audience.
Yes, we're getting a lot of questions tonight about care for adolescents. For instance, Tish Schultz tweeted a question for adolescents that need a higher level of care. What in-county resources are becoming available? Level 4, for example. And then I'd like to ask this Kirsten Jackson. Would you raise your hand? Right over here. Kirsten has a related question.
Hi, I'm the paralegal at the Public Defender's Office. And my similarly related question, and I don't know if there's anybody here from Charlotte Mecklenburg Schools, but I would kind of like to know, and this is related also to Chief Monroe, maybe he could address it if there's no one here from CMS, but.
There is. We have someone from CMS as well.
What is CMS, and possibly in conjunction with the Charlotte Mecklenburg Police Department, doing to try to divert our adolescents from picking up charges out of affrays or assaults from in school that's happening in school, and try to divert them from the criminal justice system? It seems like recently coming through, at least what's coming across my desk at our office, is an increased number of adolescents with charges that these kids appear to be having mental health issues.
Well, I beg to differ, because I think within the last year and a half, we've seen a tremendous decrease in the number of youth taken into custody And that's primarily because we took the initiative and with partnership with others in the criminal justice system to divert kids out. I don't believe that we should use arrest as a form of discipline or punishment for what in many cases is childish behavior. But we also have to recognize as a state, we're one of only 2 states now in the country that still considers a juvenile at the age 16 as an adult. And I think that there's a lot of work that has to be done in that area, but we've met with all of our school resource officers over the last year and a half, taking them through a host of different training scenarios so that they can recognize and weigh out different offenses and remove the majority of those offenses into the non-criminal status in 2 ways. One, we divert them straight from school into various programs. Number 2, we met with the judges and district attorney whereby we will hold charges in abeyance, not file that charge based on that child taking other courses or other measures to correct that behavior where that charge won't come to bear. So that's one of the things that we're trying to focus on to try to move more kids out of the criminal justice system as a whole, not just those that may experience mental health issues, but juveniles as a whole.
And I wondered if Mr. Indris would address the other question that was, for adolescents that need a higher level of care, what in-county resources are becoming available?
At this point, I'm not aware of any new county resources that are going to be made available to address the highest level of care, level 4. I will say that one of the things that we need to look at is how we can address and divert some of the kids that are currently in that level of care and provide more appropriate services to those kids, those youth, and their families in a community setting. Once you remove a child from the community setting, they begin to have more problems in school when they come back, and the research out there really does not support any sort of long-term treatment interventions. Long-term meaning anything over 3 months. We need to develop a community that is willing and able and capable of addressing the needs of our young people in our community, so that the young people that really do need the most restrictive levels of care have access to it, and they're not sitting in detention or in other levels of care that are inappropriate to address their needs.
Did that answer your question? Karen Thomas is here from CMS. Karen is the Executive Director of Support Services for CMS, and we've written recently, yesterday, about the number of school-based behavioral health specialists has dropped, and you all are really lacking resources right now in that area. Can you talk a little about that?
Yes, thank you for the opportunity to address that. One of the words that I have heard repeatedly tonight that I think is a key to solving it together is collaboration. And currently in CMS, we are really understaffed with our support services, folks who are in the schools. That includes our counselors, social workers, and psychologists. In 2009, when we all remember that severe economic downturn, we had many cuts in our services and have not yet recovered from that. And so part of the collaborative work that we're trying to put together now has involved some conversations with Michelle Lancaster from the county, and also some conversations with Met Cares. We do have some intervention team specialists that started as a result of work from a grant with Met Cares. So we recognize, and I appreciate Ms. Rash's data on the number of children that are experiencing mental health issues. And we know that we cannot address all of those issues as from the school district. We've got to have all of us working together to address this situation. But I firmly believe we need more staff in the schools to be those frontline folks to help children with their mental health issues.
So is that, I mean, that sounds to me like purely a question of dollars and cents.
It is a question of dollars and cents.
Commissioner Cotham, is there any money in the budget for more?
We certainly have talked about this, as well as the school nurse program, and just like the security program for CMS. So, you know, we're always, whenever we have money, we have to take it from someplace else. So, you know, it is really difficult with the budget right now, and because of the security work that the CMS wants. So, but I know we need to, we need to look at all these things, and I know as a board we will. But these are hard decisions, and we need to make them as a community. So please know this is something that's very important to the commissioners.
Yes.
You're right that you cannot do this on your own. And one of the things that I see in the data when we look at the kids in need, while 56% of the kids needing mental illness are served within the state's public system of care, and while 21% of those with developmental disabilities are served within the state's public system of care, only 10% of those needing substance abuse services are served within the state's system of care. And that is a place where services have got to expand. The other thing that we see is as students transition out of schools and into the adult system of care, the lack of continuity of services falls off, and that's when we lose children. And so that's another particular area of concern that I think we have to pay attention to going forward.
And it's not just a schools issue, there's obviously, I mean, there's a lot of other avenues, venues where you kind of encounter the children, and there's a lack of inpatient beds for kids and teens as well.
Yes, Chris Wynn, would you raise your hand? Yes.
Thank you, Rick. Honored to be here. Megan, I want to come to you on something here. You just said that we can't do it separately. We got to work together. You know, it seems to me that in North Carolina, certainly, we've got somebody that stands up for health care, more traditional health care. We got somebody that stands up for tax reform. We got somebody that stands up for education, economic development. But it seems to me that mental health does not have a champion, that no one is willing to stand up, put a stake in the ground, and really carry this flag, to use another metaphor. Is that the case? Is there anyone out there that we don't know about, or does there need to be someone pulling from the front and not just the gang in this room that are pushing from the back?
Chris is one of my board members, so there's a fair amount of pressure here.
Y'all pass her the mic.
In our research, one of the things that we saw, one of the, I think, sad things about mental health reform was that North Carolina lost its Mental Health Study Commission. And the Mental Health Study Commission in North Carolina had been a national model. And I think it had been a national model for three reasons. One, it had independent staffing. It had independent staffing separate and apart from the division and the department, separate and apart from the legislature. And they looked at these issues, and they developed 7 long-range plans that guided policymaking in this state on mental health reform and mental health issues. And I think we are missing that. The other thing that the Mental Health Study Commission did was that consumers, there wasn't just token consumer representation. Consumers were an active part of the Mental Health Study Commission. They had voting rights. And we need a policymaking forum where that is the case, where all of the people that are stakeholders in the system can come together and can do what you're talking about. And that's also how they developed legislative champions on mental health issues back in those days. In the meantime, I am hopeful that the managed care organizations, the MCOs, will step into that role in their communities. When we looked at Piedmont Behavioral Health Care, which was kind of the pilot model for this, one of the things that they got from the waiver was the ability to become advocates for the people that they were serving and to try to identify providers that would provide the right mix of services for their community. So that may happen, and we're hopeful that that will happen.
Can you,
I'm not, Taylor, I'm not an expert on this issue, but I just do want to comment on it. I think you're absolutely correct, and I come to a lot of different forums, a lot of different community meetings, but just looking out in this audience and seeing the number of people that are here tonight that care about a single issue is probably the most powerful statement that you can make to anyone, whether it's law enforcement, whether it's the state, or whoever. If you have that care and that concern and that passion, you can make a difference. But I think that we all have to be willing to, again, pull back the curtains and go through it, the door, and make it an issue that you're not afraid to talk about every day. Because the stories and the crisis that's out there facing individuals with mental health issues is scary. It really is. You know, what we've experienced just in law enforcement this past weekend involving our young people, but there's a secret around it. No one wants to talk about the real issues of what happened, what's happening to our children. We find other ways of disguising it and making it a tragic accident, but it's more than that. These kids are suffering out there, the challenges that they're going through, the things that we're seeing them involved in. It's a crisis, but we speak about it in other terms. So I believe that just the power that I see amongst the group here tonight can really help make a difference and bring about real change.
I'd like to echo that, and I think as a new LME MCO that we need to listen to our consumers, our family members, and you know, we have a mechanism in Mecklenburg County to be able to do that, and I believe every LME MCO has this as well, and it's called the Cfac, Consumer Family Advisory Council. And that has a tremendous input into how we think about the delivery of services in our community, and it should be driving that level across the state. And when we begin to listen better and the CFACs begin to have a political voice in Raleigh, then I think then we will have some real substantive progress in the delivery of services across the state.
As long as, while we're talking about the state and advocacy behind that, Chris, I thought that was a good question. The state has, seems like they're reforming the mental health care system every few years. But they, from what I can tell, they're sometimes throwing the baby out with the bathwater and not keeping some of the good aspects of what exists. Ms. Rash, I'd be interested in your take on some of the biggest aspects in recent years from the state level of what are the biggest mistakes they've made, and you know, is there a or do we have another couple hours? And is there something, you know, that they need to do, or do we need to let this latest one play out before they really?
So I think the biggest mistake is just the lack of instability in the system. When we look at mental health system across the country and evaluate how well they're working, states that have good systems have identified their mental health strategy, they've implemented it, they've funded it, and they leave it in place long enough to evaluate it and make meaningful change. In this state, it seems like there are major changes in policy, in funding, and in leadership so frequently that often the state's biggest problem is its inability to stay the course. And so I hope as we move through with the conversion to managed care organizations and the waiver that there will be patience for us to implement it and leave it in place long enough that we can really go in and make some meaningful evaluation and have good positive changes come about from that.
Given that the question was kind of directed at me, I'm new. I've been here 7 months now, 6.5 months, I guess. So I really can't address it, but I think that one of the critical issues is that behavioral health care reform is part of national health care reform, and it's an evolutionary process. And, you know, I'm not familiar with all of the changes that have taken place in North Carolina over the last 10 years, but where we are now is not that dissimilar to where other states are in terms of moving toward a managed care system. As was pointed out earlier, some states are doing it as a segregated system. Other states and more states are doing it as an integrated care system. But this is part of an evolutionary change that North Carolina is undertaking, and I suspect that in the next, you know, as we learn more about delivery of services to individuals with mental health issues and substance abuse issues here in Mecklenburg County, we're going to do more and more about integrated care, whether it's through our PROACT model with the emergency departments or with CCNC and looking at the data in a much more holistic and integrated manner. This is part of the evolutionary learning, and I think that I'm willing to give the state some kudos for allowing this to happen. Other states may not be there, but I think that North Carolina at this point is on the verge of moving in these directions, and it's a very positive direction to move into.
Thank you. We have time for just a couple more questions, 2 or 3 more questions. Something we haven't touched on much so far is homelessness and housing, and that's a big piece of this. You know, the vast majority of homeless people suffer from some kind of mental illness or behavioral problems, and Moore Place has been a wonderful addition to this community, serving the chronically homeless, and you know, I kind of feel like we need more and more places. Is John Yeager here? John is with Urban Ministry Center, and I'd like you to talk a little bit about you know, what needs to be done around helping homeless individuals, specifically through the mental health lens. And then I might ask the panelists about what can be done to provide more housing and supportive services to severely mentally ill individuals.
Well, I think the Housing Works programs with Urban Ministry, one of the things that we've done differently is we've used a housing first approach. We don't say that you got to get clean and sober first. We don't say you have to be on your meds and stable first. We say, come and get housing, we'll help you with that. And we're showing that that's successful. And we need more housing first. Well, first of all, we need more housing, period. But using that housing first model where we can put people into housing, once their basic needs are met, now they can focus on taking care of those other things. But it's really hard to think about going to get your meds or getting substance abuse treatment when you don't know where you're going to sleep tonight. Or if you're going to sleep, if you're going to have shoes on when you get up the next morning. So having that stable place to live is really the first step. We need more of that.
So is that, I mean, I don't know if y'all could hear all of that, but you know, housing first. If you have a roof over your head, you know where you're going to sleep, you're more likely to be able to deal with your other things that need to be dealt with. Does that mean building another Moore Place? Does it mean, I mean, there's a lot of different ways to provide that housing.
Well, it could mean building another Moore Place. We also have a scattered site model that where we place people in apartments throughout the community and work with landlords. We have case managers that go to people's apartments, and that's also very effective. So it doesn't necessarily have to mean building more buildings, but it does mean having access to more apartments.
Well, and doesn't it mean then providing the supportive services that they need? I mean, the roof won't magically do it. You also have to provide a lot of supportive help.
Well, aren't homeless just because they don't have a home. There's also typically other things that they need. And so the support services have to be in place. You have to have people who know how to access the system or have mental health, substance abuse knowledge themselves, and can work with the people, increase their motivation to accept treatment, and and then help them get into treatment, keep them motivated to stick with it, and be there when crises do happen. Because just because someone's homeless doesn't mean that there won't be any more crises.
Sure.
Someone has to be there when that happens.
Commissioner Coughlin, what can the county do to help mentally ill individuals who are homeless?
Well, there's probably a lot of things we can do. Certainly, we need to help to educate people. And I also really believe in working with the nonprofits more can also be a big help. Homelessness, I worked with a lot of people who were homeless, and I was able to get a lot of them out of the shelter, which is always the best thing in the world, to get somebody out of the shelter. But, one thing that we're not talking about that I think is part of this, a lot of these people who have mental illness can still have a job. A lot of them can have a job. And we need to we haven't talked about that, and I think and it's the same thing with people with criminal records. But a lot of them, I have found jobs for, and they are still very successful in their job. It may not be a job that you might want, but they're very happy with it, and that can also help them get out of the shelter. So, maybe that might be another topic we might talk about sometime is jobs, because that is a constant theme with this population as well as with the overlap of people with criminal records. And there's a lot of places that, including the housing authority, that, will not rent to someone who has a record. And it's a real problematic. And this is something that I went to visit. I helped a woman who just got out of prison last week, and I helped her find a place to live, and I went to see her on Sunday, and and I was able to vouch for her because I'd known her for a while. But if she didn't have me as someone to to vouch for her, she would really be in a problem. And she has 2 college degrees, and but she just got out of prison, and so, this is, but again, we need to think about jobs, and there is a lot of discrimination. And we haven't talked about vocational rehab because that's another nonprofit that helps a lot of people who have disabilities.
Thank you. Rick has another one from the
Yes.
audience.
Is Zach Gordon here? Zach, yes. Let's see. Well, you're right in the middle, aren't you? Yeah, let's get right over here. Zach raises a question that many other people have raised tonight, and it is regarding hospitals.
It's coming.
Sorry to Dr. Ray. The question really is, it seems to me that, and our daughter had a situation very similar to the story earlier, overdose, went into the emergency room, and I hear the stories about people 20 times a year. Seems like the hospital is the place to have a facility so that whether it's a police officer or someone else, crisis could really go there. And my question really is, how can the hospitals be encouraged or maybe required, to use a euphemism, to provide that service? Because really, it's 2:30 in the morning with the problem. What do? You don't want to take them to the county jail. You don't want to bring them to the emergency room. Our daughter was there for 3 or 4 days, and then fortunately we were able to get a bed an hour and a half away. So that really is I think, when it comes down to funding, I know, but it seems the natural would be those hospitals that seem to be sprouting up in every community to, be a good place to take them.
A couple comments. It is a bona fide crisis, and access is not adequate. And much like law enforcement, in a certain sense, becomes the last line of defense in a clinical sense, hospitals and emergency rooms that people come to work to do the right thing. And if that wasn't enough, federal law has a lot to say about what we need to do in emergency rooms to help stabilize those who are in emergent medical condition, are the last line of defense. And the crisis is such that the shortages are extreme, and therefore the stories that emerge from that are at a minimum frustrating and confusing, and at a maximum tragic. And they're easy to find, and that's what we're all here, brings us all here today to try to figure out, I think. There's no doubt that going forward, we have to both do more and do better. We, Carolina's healthcare system, is convinced we need to do more, and that's why we have doubled down as it relates to capacity with a new behavioral health hospital in the Davidson community at a time where the math does not support it, the finances do not support it. We even deal with some criticism to do it, but it's the right thing to do, and we are committed to trying to build the capacity that, even as the last line of defense, will be better suited to the need than what we have today, as we all recognize there's just not enough. The interesting discussion is, once we have more, how do we then do better? And that's where the interesting discussions, I think, of potential partnerships and collaborations and changes in the model, learning from ourselves, given more time for the model to work, and also from other states, as Mebane was talking about, may give us some tips of some things to try that heretofore we haven't been either in the position to or collaborative enough to be able to try. So I'm proud to say that we are committed for hospitals and health systems doing their part. And I think we've demonstrated with some courage our willingness to do that. But it is our part, and everybody in the room and everybody represented on the panel and in the first three roles has a substantial role to play that we can't or shouldn't. It's really a community coming together to watch after its citizens' health needs together. And so we stand ready to work with others to do their share. We'll do our share, and I think there's benefit for all of us in that.
Dr. Ray is with Carolina's Healthcare. We also have a number of Presbyterian Hospital representatives here today. Novant, I guess, is what I now say. Dr. Greg Clary is the medical director for psychiatry at Presbyterian. What would you echo what Dr. Ray says, or?
To a certain extent, yes, and to a certain extent, no. I mean, the reality of things is there's no room in the inn. And the question becomes, with the lack of resources, with the lack of integration, what can we do to help our patients to ease their suffering? And I think the key element in any of this is a community, that there is room in the community and what the community can do. I've been at Presbyterian for a little over 60 days and got, in the last 60 days, been swept into reality. But luckily, given the support that we've had, I've made contact with MedLink, and we've discussed options in terms of bringing the acute crisis team into the emergency room at Presbyterian to assist with disposition. Actually, in 2 days, I'm meeting with the psychiatrist at CMC Randolph so that we can try and establish better communications on similar patients in a way that doesn't violate the governmental rules, but best helps the patient and helps the system deliver care that's necessary. The child situation is, to be quite honestly, a disaster. I've got 5 children in the emergency room waiting for beds at our hospital with essentially no other disposition options, that we contact other state facilities. And I'm not trying to point fingers at them. Again, there's no room in the inn. And we're doing the best that we can given the circumstances that we've got. I think Presbyterian, I think CMC, I think the county, everybody is making the best effort possible to make inroads, to make this work. But the problem becomes, how do we as a community, as a city, as a state, as a nation, because this is nothing new. I mean, deinstitutionalization was in the 60s. We've been chasing our tail since then. How can we do things better? How can we recognize the problem better? How do we not make this a competition and make it better? The question there, I don't know what the answer is. I'm trying. Presbyterian is trying. They certainly are giving me plenty of rope to try and do things in a better way to help the patients and to help the community. But I think things like this, integration of systems, whether it be, I worked in the prison system. Embarrassingly, I was a resident at Duke, and I was the state psychiatrist in 2 prisons in northern North Carolina. That's how pitiful things are. But the difference between the patients I saw there and the patients I saw in the hospital at John Umstead was, where did the officer decide to take them first? So I think we can all do better. The question is, what's the best step?
Well, I don't know that that's an uplifting answer, but it's a realistic and it's probably a good place to leave things this evening. Really deeply challenging problems with no easy solutions, and you all knew that coming in. But we wanted to start that conversation, and I hope that this is a beginning and not an ending of talking about these issues. Let's give a big thank you to our panelists. I think our panelists are going to stick around. We have coffee and desserts outside at the reception. Different agencies have booths set up. The National Alliance on Mental Illness is here, so please join us and keep the conversation going. Thank you all for coming.